needs, the community needs are absolutely pressing and knocking on our doors. 6 is changing perceptions. And I think we are at a moment in changing perceptions around mental illness around the globe. We are all in different places. I frequently refer to Dr. Saxena's quote that when it comes to mental illness, every country is a developing country, but perceptions are changing. And new knowledge. The 7th variable is new knowledge. And we have an enormous amount of new knowledge in this field that can be put to work. So it's in that spirit that I'd like to invite each of these folks to share with us their reflections, their observations about what the priorities could be and should be. What do you know? What do you believe? What do you wish? And I've asked each of them to speak for no more than 6 minutes. A few have slides and a few don't, so we're going to start with those with slides. And we will begin with Danielle Kemmer. Danielle is, hold on one sec, let me make sure I get Danielle's title correct. Danielle is Vice President and Executive Director for the International Alliance of Mental Health Research Funders, and as Vice President Strategy and Initiatives, Danielle is involved in strategy development and oversees the Boeckh Foundation, their practices and activities, and is really in a pivotal position around how to think about global mental health funding. And welcome to the podium.
So I hope that oh yeah, it works.
Yeah.
Thank you. So I would like to thank the organizers for giving me the opportunity to add a philanthropic perspective, not the first one, but one of the philanthropic perspectives to the meeting. And I will try in the 6 minutes to give you just a few key points to the lessons we learned from our work in the mental health sector and the mental health research sector. And honestly, I don't think there's a single point up on this slide. I have one slide for 6 minutes. There's not a single point on this slide that you haven't heard about in one shape and form during this meeting. But I think that if you think about this in the context of research and policy agendas, it might slightly, you might think about it in a slightly different way. And so I just want to make these points once more and give them like the specific context. So the first point, well, coming from philanthropy, making a difference for people, helping people, I think the most important thing is impact, and impact for people in a relatively short time frame. And so if you think about research and policy agenda, so how can you do that? Like, research takes a long time, development of treatments takes a long time. So one of the things I think that's key to at least making the time a little bit shorter is to putting the individual and the patient at the center of any research or policies that we're trying to develop. And when I say that, I mean, so starting with things that work and basically work our way backwards, like start from effective interventions and try through the research efforts, try to understand how they work and what happens. Another important point, I think, when it comes to the research agenda is the consolidation of different efforts and studies that are currently ongoing and that have been going in the past. A lot of good work is out there, but we really currently don't have the platforms and tools to share this work, to increase cohorts on the one hand, like to really make studies more meaningful, and also to really share amongst the global community, like both in research efforts, but also policy agendas. So creating platforms that allow accessibility for the greatest number of people, if you want. And my third point, and that's probably the most important, is the co-creation with individuals and families that are affected in the sector. And when I say co-creation, I know this was mentioned during these 2 days at several occasions. I'm not talking about tokenistic representation of a youth and a research project. So I really mean like the full integration of patients, youth, and families in the research efforts, but also the governance structures, in the evaluation panels, like really the way we conduct research to make like patients and families an integral part of the entire process. That was my point on impact. The second one is partnerships. I mean, no surprise there. I think we all think about partnerships. However, effective and diverse partnerships, and I think that really reflect the complexity of mental health. Mental health is extremely complex. There are many, many partners out there that we should interact with. And so if we think about the broad determinants of mental health, so I'm talking about biological, social, environmental, you name it, determinants, we really have to think about a wide range of stakeholders we want to engage with. So this is a very important piece and task. Break down silos. Especially we as foundations see our role as an important one in helping breaking down the silence, like being kind of a neutral entity, a convener to bring parties together. And the third one builds synergistic links between sectors, across sectors. I think we've heard a lot about this like during the last couple of days. And my last point is the focus on transitions and integration. And so we've heard, my first point, we heard a lot about it, like distribute mental health services from institutions and provide effective care in community settings. But when we think about severe mental illness, there might be some back and forth between institutions and the community, like the community sector needed. But those transitions, like building the bridges between the institutions and the community sector, is actually a great challenge, and it's not an easy thing to do. So for that, we need targeted health services research to really better understand those transitions and make them more effective. And lastly, to treat and investigate, so do research across a continuum. And when I say across the continuum, I mean when we think about mental health, so from mild to moderate to severe mental illness. So mental health is not a static point in time, like there are variations, it might change. And also research, like really working across the continuum from basic biomedical to clinical, all the way to health services research. So that's my message.
Thank you.
Thank you very much.
I would now like to invite Dr. Abe Fekadu to share his reflections. I'd like to thank him for being the only male on our panel. And I would like to say that he is clinical professor of global mental health and head of the World Bank Africa Center of Excellence in Therapeutic Discovery in Addis Ababa University in Ethiopia. He's clinical professor of global mental health and head of the World Bank Africa Center of Excellence in Therapeutic Discovery, is a leader across the continent and across the globe. Thank you for being here, Abe.
Thank you very much for the nice introduction, Kathy. So I'm very grateful for the opportunity to be here. I feel completely honored to represent at least the voices where I've come from. In this second, I just would like typically acknowledge my funders in all the presentations. So I just would like to quickly acknowledge NIH, DFID, NIHR, MRC, Wellcome Trust, the British Council. Although this doesn't represent their view, I would like to acknowledge that. And I would like to acknowledge some of my colleagues and international partners here, Professor Ezra Susser, Professor Graham Thornycroft, Dr. Alex Cohen, Dr. David McDade. I hope I haven't forgotten many of you, so I just want to start with that. This is an image I got from a colleague from South Korea. We have been working I have been working with him in the past 4 months, and he's returning to South Korea, and he wanted to give me this image. And the reason he gave me this image was that he understood I was in a complex environment. I was leading a center, CDT-Africa, which is completely not within my specialty. It requires to engage with many people across the globe, essentially, and to encourage colleagues within the college to work with me. And he said, the work you are doing is absolutely essential, but it's a difficult job. And this is how I imagine mental health leaders are across Africa and perhaps in many low and middle income countries. The work they do is essential, but there are not many. And I think although we didn't really focus on this particular issue, that's my observation. Often I travel to few meetings like this and I come across similar people almost all the time coming from Africa. These people are essential people. They are in short supply. I think one of the major priorities I advocate for is supporting programs that would encourage scientists to be scientist leaders. I think that's a major bridging principle for me. And whenever I work with the ministries, I rarely work with the same junior minister or someone after 2 years. So that's a common switch. So in terms of coming to the specific priorities, I think there is no shortage of policies in Africa. There are many policies. There are many strategies. And I pick up two samples from Ethiopia. For example, in the health sector development plan in Ethiopia and transformation plan later on, there was a clear strategy to include mental health in all the primary health care provisions. We didn't manage, it's now almost half the way to finishing, but we haven't integrated mental health care as we should. The resource was there and everything else was there. So I think that's one of the things. Sometimes we leverage the principles that are already in existence to work, but this was completely explicit guidance. So working within existing policies is extremely important. The second principle related to this is having policies ready. The current guideline on physical health, the HLL guideline, is essentially this. So we wait for our time and we present it. It's always good to have policies ready for opportune times. The second principle I want to emphasize is making treatment available. So in my experience, for example, we have a large project called PRIME. We integrated mental health care successfully. Constantly the problem we had was making sure medication was available, psychological treatments were available. And that's a major issue across Africa. My answer to this, because I'm linked to CDT-Africa, is medicines have to be produced within Africa. And that requires innovation and thinking, but I think a group like this and others should actually consider advocating for something like this. Improving quality of care. In Africa, in many countries, the only way we could scale up services for serious mental illness and epilepsy, and we have demonstrated that could be done, is through integration into primary care. But that requires improving the quality of the whole primary care work, not just mental health care, and adding some quick elements. So I think integration is for the next 20 years. Mental health care for serious mental illness, particularly in Africa, could only be provided, I believe, through integration in primary care. And I think it's absolutely essential we do that, ensuring quality, and policy is relevant to that. And this main emphasis was already said. This young lady, or maybe not so young, she looks very happy. And the only reward she had was through the program, her husband was well and he was helping her. But she lives from day to day selling firewood. People like her need support, and policies to support that, I believe, are absolutely essential. Encouraging resilience in families is absolutely essential. And one of my major advocacy is around homelessness. In Africa, in the capital I come from, we have a population of about 5 million. We have nearly 100,000 homeless people. A good proportion of them we know, we have done the study, about 40% of them have serious mental illness. And that's much bigger than what you'd find in high-income countries. And part of the reason is the lack of service in these countries pushing patients out from the rural villages into the cities. Something definitely has to be done. And I did love the Fountain House model very much. And we have demonstrated something could be done about it, and policies and research support for something like that would be essential. And finally, I will finish with this slide. Community engagement. Communities could do. I'm talking about 2 communities. Member communities, as in Fountain House, would be one example. I'm also talking about the broader community. When the broader community, especially in countrysides, understand what miracle could be done by providing care for people with mental health need, they engage completely. And I could give several examples from our PRIME project. And I believe that's absolutely essential thing to do. So these are I've got a few more, but I think these are my priority recommendations. Thank you so much.
I would now like to invite up Maria Cavalcanti, who is professor of psychology at Rio de Janeiro Federal University. And Dr. Cavalcanti has been instrumental in leading adaptations of the community-based psychosocial intervention, critical time intervention, as part of the Ready Americas network. So she has a real perspective on global collaborations, global research, engagement of non-professionals in care, and can help guide us in thinking about what some of the priorities should be from your perspective. Thank you.
Yes, thank you to be here. I was very afraid of this moment because my English is not so good. Then I said to Kathleen, how can I have a conversation for all these people in front of all you? And I don't know if I can speak in English for that, but I will try. And it was, I did 2 slides that can help me. But you asked us what was the unexpected subject that arrives from this conference. And I am here, me and Andrea. I think that we are the only Brazilian here, Brazilian people. And what was very interesting for me, it's many people told us that the most important thing to invest is in human being, human capital. And we are talking all the time, me and Andrea, I want to do this and this research, this is important for our country, but who will do this? And I was thinking in my life, because many people did a lot of shared experience. I did not commit suicide, or I'm not so normal, because I think nobody is normal completely, hopefully. But I was thinking that my country invests a lot on me, my education, and if I can be today with Andrea, it's because there are a lot of investment in my education, in my life, not only for my parents, but for my country, my government. And I think that it's very important that you can give again to our country everything we received, and to the world. The same way that many people told here, I had a mental illness, but I have many things to give to everybody and to our society, to our country, and to our world. And then it's my first thing that I think that was very unexpected to me, that I can do this kind of reflection being 2 days here with you. Because when we go out from our country, our space, then we can see many other people from other parts of the world, then we can reflect about our small piece of world. But it was not this that Kathleen asked us to say. Then I will talk to you some priorities. I think that it's very important policies. But we heard from the other speaker now that we have a lot of ideas, but the political man is like fox. And what's very difficult is we have the ideas, but how to do this, how people can do this. And I can share with you some policies that I think that are very important, and many people told about this in these 2 days. is the integration. Integration is a word that we heard all the time. We need integration, mental health with primary care. We need a cross-training for the intersection integration in mental health. Mental health, it's a field that it's health, it's social, it's employment, it's house, it's love, it's so many things. How you can do that these things really happens. I think that is the most important. How motivate people and have people to do these things, to be with people, to be together. I think this is the most difficult things to achieve. Training the health students with professions, including community health workers together with lay people in mental health. Yes, this is another issue very important. Now what we are doing in my university, it's the Federal University of Rio de Janeiro, that we are training our medical students in primary care in mental health. We have 130 students in many family clinics, many primary care centers, and they are doing the training in mental health in this setting, not in the specialized, not in Psychiatry Institute. They are with people, with poor people, with environment, looking and thinking about mental health. And then when they arrive, because in the course, it's very strict. It's the SEM is how I can see if this person is schizophrenia or bipolar or OCD. And then they arrived, and we have a woman that the kid was dead by violence. There is no father, there is no food. And then they ask me, what is the diagnosis? That's the question that students ask me. And then I think, what do you think is the diagnosis? It's a problem of mental health, it's a problem of life, how you can lead with this. And then for that, this training in the real situation of life is very important, because these medical students, they will be doctors after, and then they will have experienced this. And this will be very important in the practice they can do after. Okay. Programs that destigmatize mental illness, especially for young people. Okay, many people talked about this. The other one is the priority of research. Can you change, please? Yes. I think in the subject of this conference, we have a lot to do in Brazil, because we don't have really the rate of patients with severe mental illness, that what is the rate of mortality. Then there is a research, we need to find people to do this. We had a big experience in the Brazilian psychiatry reform. We have more than 3,000 mental health community centers in Brazil, and this is a very important thing to do, is to evaluate how this more than 3,000 community mental health centers really are doing. And this is very important in this political moment that we are living now in Brazil. I think that everybody knows what happened there, because our reform is really in danger, and we need to prove that it's these centers and all these ideas, they are very really efficient. And what's the mortality rate of the patient treated in CAPS? I think that something that we need to try to see very closely also. Thank you.
Thank you. I would now like to invite Dr. Glenda Wrenn to the podium. Dr. Wrenn is the Chief Medical Officer of 180 Health Partners, where she provides executive clinical leadership for its programs that address the social determinants of health. The Strong Well program that she directs focuses on opioid-dependent pregnant women. The certified multidisciplinary Strong Well care team fills in the gaps of care and addresses critical access to care challenges that prevent the moms from receiving the care they need. Dr. Glenn has dedicated her life to health disparities and has done so in multiple contexts. Prior to this position formerly was the director of the inaugural director of the Kennedy-Satcher Center for Mental Health Equity in the Satcher Health Leadership Institute at Morehouse College. So Glenda can speak to the issues of disparities for us from multiple perspectives, and we'd like to hear what your thoughts are.
Thank you, Kathy. And thank you for inviting me to be with you here today. I don't do global mental health, so it's a very interesting perspective. I really focus on health equity as broadly defined. And one of my mentees, Gigi Bastien, is a global mental health person. And she was the one that inspired me to realize that here in the United States, we have so much to learn from low and middle income countries because they don't have the opportunity, they don't have all these resources to fight over, so they're forced more to collaborate. So I definitely appreciate the opportunities to go global and take all of the things that I've learned from many of you doing work in your countries back to thinking about my new role in creating this new model of care that's primarily a peer-based model, and the specialty services are designed around these moms that are in recovery themselves, helping to engage moms like themselves to address this crisis in our country. So I thought I would share my reflections with you about these past couple of days and what I'm taking back with myself, and maybe I have some questions for myself that maybe you'll share and be able to answer for yourself. So I really think I'm a synthesizer. So I think of three main things as it relates to this challenge that we're talking about, improving the lives for people with serious mental illness. So vision, voice, and value. So within vision, I have a personal vision for mental health equity, so I have something to say about society in terms of that vision, but also systems and science. We were asked to talk about policy and research. So my personal vision for mental health equity, which I think can be translated to global mental health equity, is that all people have the opportunity to get high quality care when they need it in settings where they feel welcomed and safe. And for that vision, people need three things. The first is confidence that their inherent human dignity is not going to be violated by the systems and structures when they go to seek care. We heard the first day from Ellen Sachs, who herself has kind of dedicated her life to making that be true. So thank you again for your work in this area. And the second, it has to do with knowledge. And we've talked a lot about information and how people's mental frameworks and the knowledge that they have or don't have around these conditions influences their willingness to seek care, their willingness to support funding for care, and so many different things. So I believe that we need to have accurate knowledge about mental health conditions, their prognosis, the treatments, just as common knowledge as we would know anything else that we know commonly, just as commonly as we know what you should do if someone looks like they're having a heart attack in an airport. So that needs to be reflected in our media, in our schools, amongst our policymakers, and that means that we that have this knowledge need to get outside of our four walls and communicate that knowledge clearly and effectively to society. And then science, someone said earlier that we already know what works. I think it was Patricio. We do. We know a lot about what works. So I always get a little bit uncomfortable in my seat when people say we need to do more research, because I think so much about how much research we already have that we're not implementing. So we have implementation science, that's wonderful, but how are we here collectively as a group elevating and scaling what we already know works? And as it relates to science, if you're gonna do new science, fail forward fast. So in the realm of this work, how are we, the process for getting grants and doing research is so long, by the time you get the grant, you're no longer interested in the first question that you asked. That's just how it is. And we're only funding 20%, so are those other ideas just horrible? Probably not. Who's doing something with those ideas? There's so many orphan ideas that are sitting on the shelves or in someone's share drive right now, so I would challenge the philanthropic community as well to think about how can we make better use of those resources. And health equity is all about aligning resources with needs. So think about that. So around voice, I was really inspired by the individual who there was actually several people that stood up and talked from the perspective as an individual who identified as having a serious mental illness and kind of longing to have more of an influence and more of a voice. So I wanted to just share my thoughts about that, because I think that representation without influence is tokenism, and we've talked about that. That's about having a seat at the table. But representation without support is also tokenism. And these are individuals who often have gone from actual tokenism to, okay, great, now you're at the table, but I've never been at this table before. Where do the forks go? Where are the courses? How can I plan? Those things are really our responsibility as the hosts of the table, so to speak, to make sure that we intentionally put the supports in place for those individuals so that they can succeed. I feel strongly that this is important. Obviously, I'm a woman of color, and I've often been in what I call pale, male, and frail advisory boards. Yeah, so I built my whole career filling in for Dr. Satcher when he wanted to retire. He sent me to things instead, so I was like, oh my God, big imposter syndrome. But what I realized very quickly was that those individuals did not even have access to the questions that I had access to, and that was really the single most important value that I brought to that table. As well-meaning as they were, as open-minded as they were, there were things that were so clearly obvious to me. I was like, no one else sees this? Okay, well, I'm gonna say something about that. And that personal experience, I think, is something that individuals with severe mental illness also may be challenged with. Like, this seems really obvious to me, but these super smart people aren't saying anything about it, and these policymakers don't think it's important, and aren't these solutions as clear to you as they are clear to me? So where the gap that we need to fill is how do we provide the supports for those individuals so that their human capital that they already bring can be better leveraged to help us solve these issues. And then look around and who's not here? Who's not in the room here today that we think could benefit from what has been shared over this last couple of days? And the last thing I have to say is about value. And this is really a challenge to those of us that are working within the system. How can we better show our worth so that each stakeholder can see their own data? So in policy, no one cares that you're doing that in Ethiopia if you're in Arkansas. They're like, I'm really glad that works in Ethiopia, but we're in America, we're in Arkansas. They want to see their own data. Even though you show them their own data, it's the same thing that's true for integrated care. And within the United States, it's no worse. That works in California, that's not gonna work in Atlanta. We're very different, our patients are different, our issues are different. We know it's not true, but you can argue, or you can just say, here's your own data. Here's the exact amount of money that you will save by doing this intervention. So I think that's, that framing issue is something that's important to remember. And we want to measure what matters, both to them, whether that's medical costs or medical outcomes, but also to us. And the last panel, I think, really spoke to that and that challenge of measuring morbidity and mortality and owning that as an outcome that we can't go to sleep at night thinking we're successful if our patients we're caring for are dying. Like, that's just not success, right? That's not an acceptable outcome. So until we're monitoring outcomes like that, then we're not really measuring what matters. It doesn't matter if you're hearing no more voices, if you're still not working, you're not engaged in meaningful relationships, your talents are not being leveraged in our society. That's not a successful outcome until I've been able to work with you to get you to that place. And that's all I have to say.
Thank you.
Thanks so much, Glenda. I'd now like to invite Susan Azrin to the podium. Susan is the unit chief of the Early Psychosis Prediction and Prevention Program at the National Institute of Mental Health. She has actually recently, in 2013, received the NIH Director's Award for Outstanding Service and has really dedicated herself to questions around serious mental illness and strategies for intervention and supporting innovative programs. Thanks for joining us.
Thank you, Kathy. And thank you to this conference's sponsors for giving me this opportunity to be here today talking with you and to engage in this conversation with you. So over the past 2 days, I've consistently heard that across the globe, we need to address at least 4 key failures on the pathway to care for medical comorbidities. First, modifiable health risk factors that are associated with premature mortality are common in people with serious mental illness, but are infrequently recognized. Second, when these health risks are identified, The individuals with serious mental illness seldom receive the care they need. Third, when the care is provided, the quality is highly variable. And finally, it's unclear how evidence-based interventions need to be adapted for people with serious mental illness who may experience cognitive and functional limitations, motivational deficits, social isolation, limited resources, limited access to healthcare, and other barriers. So I suggest concentrating our research to address these 4 knowledge gaps. First, how best can we systematically detect common modifiable health risks in people with serious mental illness at the earliest possible opportunity? Second, how can we systematically increase access to and engagement in appropriate care for those health risks, especially care that targets multiple health risks, as medical comorbidities are the norm? Third, how can we optimize the quality of that care? And fourth, what degree of adaptation is needed for interventions that are effective in the general population to achieve the same level of effectiveness in people with serious mental illness? So I heard the need for a rigorous research strategy that employs population-based approaches to health risk prevention, identification, and treatment, focusing on everyone with serious mental illness in a given setting or area, whether in the community or in an institution. This calls for developing and testing system-level interventions, like universal screening of health risks and care coordination as standards of care. We should prioritize addressing the common modifiable health risks or combinations of health risks that are most strongly associated with premature mortality. And these health risks may vary by country and subgroups. So in the US and other well-resourced countries, these risks include smoking, obesity, hypertension, dyslipidemia, substance use, and poor fitness and diet. In lower income countries, infectious diseases may dominate. And we should prioritize intervening early, preventing these health risks whenever possible. Many of you have innovative programs to promote longer, healthier lives. We should capitalize on these natural experiments by measuring their health outcomes. Are they succeeding in reducing obesity, in achieving smoking cessation, in lowering blood pressure, etc.? We should examine whether quality of life improves. We should measure the service elements that are delivered and their intensity. As Gary Belkin urged us yesterday, think broadly and boldly, but act locally. So our strategies must always fit the local context if they are to be accepted and if they are to be successful. And meaningfully involving stakeholders in program development, especially people with lived experience, is essential. That will help us very much to understand the local context. Our research should identify for whom a program is most effective and under what conditions, as well as its costs. And as Kathy Pike observed at the start of our meeting, it's important to understand what works, what doesn't work, and why. This will help us to build the necessary evidence base and inform our efforts to scale up effective programs. So in sum, a research agenda to improve health and decrease excess mortality in people with serious mental illness should produce reliable data to influence policy, to quote Graham Thornycroft, and it should focus on developing and testing interventions that are population-based, that are systematic in identifying health risks as early as possible in people with serious mental illness and connecting them to needed care. The intervention should involve evidence-based strategies adapted as needed for people with serious mental illness and made available to all who need them. The interventions should be practical, acceptable to stakeholders, and fit into the workflow of the intended setting. and our research should focus on interventions that leverage the settings that are already serving and engaging the target population. As Betsy Bradley said yesterday, we should leverage what already exists. So this is what people with serious mental illness deserve, to have the chance to reach their full potential. Thank you.
Thank you. Thanks so much, Susan. I'd like to now invite Dr. Helen Herrmann to the podium. Dr. Herrmann is the president of the World Psychiatric Association. She's a psychiatrist and public health physician, professor of psychiatry and director of research at the Origin Youth Health Research Center and the Center for Youth Mental Health, the University of Melbourne, and comes to us with, from down under, and as the representative of the largest organization of psychiatrists in the World Psychiatric Association. So from your vantage point, Helen, could you share with us your reflections and recommendations, please?
Well, thank you very much, Kathy, and to all of the fellow panelists and to the people who've been commenting and contributing so richly to the conference. I think a lot of it's been said, but as Kathy said, we come from a field that's been walled off. We've been walled off from health, we've been alienated from the society, and we've been alienated from our fellow professionals in health and social sciences and other sciences. So I speak from the vantage point of psychiatrists as well as others, and I'll come back to the psychiatrists in a few moments. But so thinking of that, we're coming from a field where people with lived experience, their families, all those concerned with them and all those concerned with supporting them, kind of struggling away in a segmented part of the world. And we've also been hearing evocatively about the complex systems that are engaged in support for people living with mental illnesses and their families, but also the systems that support mental health for all of us. I mean, one of our struggles in this field is getting the rest of the community to come with us. Not only have we been walled off, but there's now persisting confusion about what we're really aiming to do, among others looking at us. So if we're thinking about what can be done in the population sense or universally to promote mental health and well-being in a community, what can be done for those that are at risk of ill health and subsequent disability, or those who are in the early stages of that, and what can be done for those people living with these conditions. In a way, we're aiming to do a blend of all these things, but it's still very important and helpful to distinguish that, and I think that's a fundamental message. And we were hearing in the economics section about health promotion as well, and such a lot's been done by you, the group of you, particularly in London, about in the UK, and about this topic that's helped the field. So we've also had the lovely image of the fox and the hedgehog. So in the complexity that we live in, how can we now remove the walls that surround us, draw in more foxes with different perspectives to help us figure out what are the pathways to success? We're engaged more and more in action research and implementation science. I think we need to ensure that our versions of implementation science are what speaks to the policymakers, make sure they're engaged in this, as well as the people with lived experience and their families. And how do we translate that into the world of development? We've now come from the era of, we have the UN Convention on the Rights of People with Disabilities that has such a lot to say about what we're doing. How do we join hands with, rather than see the world from different points of view, from the point of view of people concerned with human rights and people concerned with mental health and mental ill health. So how do we enrich the debate about that convention, and how do we look to the era that we're now in of sustainable development? And I think we in terms of psychiatry at least, the world of global mental health and the world of development and sustainable development are sometimes foreign territories. And part of the complexity of systems is that we're all boxed in. We can only do what structures allow us to do. So how do we work with the hedgehogs and say, how do we reshape systems and how do we research together to find out what works? With a couple of lenses, of course, mention the people with lived experience and the service and the family carers, and the needs of women and men separately. I was thinking of, that there's a lot of discussion now about perinatal mental health, but this seems such low-hanging fruit. If we think of the needs of the population, of those at risk and those experiencing problems, as well as the next generation, perinatal mental health, how do we ensure that this is the period around childbirth and the first months of the child's life is enriching for everybody as much as possible, and how do we protect people who are likely to are experiencing ill health? And Dr. Marquez from the World Bank wrote a lovely blog about this recently that I think says most of it. And then how do we put together early intervention and collaborative care? These are two very important initiatives, but if we think across that population to lens, there's a great deal to be gained and many similar processes that we could interest the hedgehogs in. So to finish, just to reflect for a moment on my own profession and the people I represent, how can we, the mission, if you like, for psychiatrists at this point in our engagement is how can we strengthen the capacity of psychiatrists to build the capacity of communities to respond to mental health needs, particularly in adversity or emergencies. But many of the groups that we're concerned with are suffering disadvantages of various types, and how do we use that lens to approach this? So we're looking for everybody's help to do that.
Thank you. Thank you very much, Helen. And now I'd like to invite Deborah Cassell to the podium. Deborah is Senior Mental Health Policy Specialist at PAHO and WHO, and has served there for more than 25 years, and it is a milestone for her and for the WHO that she will be taking up the leadership of WHO and has been named the head of mental health and substance use. And let's just all congratulate you. So it's true you've got big shoes to fill. Dr. Saxena's someone else who deserves a round of applause. But as much as we believe in the leadership that Shekhar provided during his tenure, we know you will provide enormous vision and leadership. And with that in mind, with the experience that you've had in Europe and Latin America from this position of speaking from a policy platform, what reflections and recommendations do you have for us?
Thank you. To make it make me feel less pressure. I have enough when Kathy started talking about ideas such as Google. So I felt that we were expecting to do something like that, and now it's also a bit overwhelming. I'm, on one hand, very lucky for being the last one to speak, because most of what I had in mind, it was already said, actually. So thank you, everybody, making my life easier. I was thinking during these days, because the idea was to focus on these days, I was thinking that we are just a small group of very highly privileged people that would come to this meeting to talk. Thanks to the help of some partners and coordinators and so on of this event, some of us could come. One person or from a country could make it, or two from a country of 200 million like Brazil could make it and could learn and share, listen and appreciate the wonderful things that are happening in many places around the world. My main issue was then, what do we need to do in order to make this available for everybody? It was said yesterday by Vikram Patel that we tend to do everything based on evidence, and I don't know if it was him or somebody, but I usually say that we know way more than what we do, but a lot more, and it was also repeated now. A lot more is known than what we do. What we don't know is how to make these things happening everywhere where it's needed. And I don't have an answer for that, but I think that the partnership that was seen in this room should be used to that scope, to find ways of, first of all, strengthening or sometimes establishing a dialogue between researchers, policymakers, civil society. We do not talk to each other. We do not do that. At global level, hardly. We are beginning to. We've been talking a lot about what is happening at global level, global mental health, but global mental health is represented by just some of us in every conference where we go, where we meet each other frequently. Yeah? Some people we keep meeting and say, hey, hi, how is it going? Global mental health. But we are just a few of us, sorry. But we've met several times, right? Yes. No, and so how do we move from there to somewhere else that is making really things happening? And so my first issue then was how to strengthen that collaboration, establishing or reinforcing a bridge between the different partners, different stakeholders that should be involved. We had a beautiful session earlier about the role of youth, and I think that that's another issue that I think we need to work more seriously in involving always at in a more drastic way, perhaps, people with lived experiences. Youth are not so young, I mean everybody, because I think that that the role of people with lived experience and the issues around multisectoriality is, they are written in every single policy I have seen in my experience so far in I don't know how many countries, but it's very hardly to be seen as an action on daily basis. People with lived experience really give their opinion, their feedback, their suggestion, their recommendations on what needs to be done, what works better for them, etc. So I think that's another issue that we need to find out better. How do we do that? And how do we advise whoever wants to listen to us that's the way of going, that is the way of going. I think that the main issue that it is my concern, and it has been, I would say, in my career, is what do we need to do? How do we need to support implementation? Full stop. I'm not talking about implementation in science. I'm talking about implementation. How do we make things happen again? What is the core elements that the mental health system has to have in order to be sure that the needs of those with severe mental disorders, but also those without the severe mental disorder, but with any mental health issues, are met, that the answers are there. The answers are there by the mental health community, but also by everybody else, because mental health could not be a responsibility of mental health professionals. I think that's why we are where we are. Because it was always seen as something apart, that only business of mental health professionals, and it is not. We learned that the experiences that work are those that are involving other sectors, actually really involving other sectors, the community at large. And so what is that core set of elements that we need to agree on, identify, define, and make a nice, easily implementable package to help others do it? And so how do we get the support from all these stakeholders to do that? I think that if we find, if anybody has the answer to any of these, please let me know. I will be happy to meet. No, but jokes apart, okay. Jokes apart, I think that we are working on it, and I think that we just need to multiply these kind of settings at country level everywhere where we are. Thank you so much.
Thank you.
Yeah.
So, Dr. Kemmer, thank you. She's got to catch a plane. So we'd like to thank Dr. Kemmer as she exits, and also thank all of our panelists for taking the time to reflect, for sharing ideas, for helping synthesize much of what we've heard, for helping spur innovation. One of the thoughts that I have as I hear people speak is that we absolutely need to think about local plus local plus local equals global, and that we need to be really working, rolling up our sleeves and being able to know how we get from that place all the way to the big ideas in Geneva and back again. So thank you everyone for helping us think about these things. Thank you all of our panelists. Please join me in expressing our appreciation.